Adam's sign. What you're going to do is you're going to ask your patient to go through thoracolumbar ranges of motion in the following order, and you're going to be looking for reasons why they may have discomfort. So the order is, you're going to ask the patient to forward flex, good, extend, good, laterally bend, both sides, and now rotate your trunk. Okay, that's the order you're going to be looking for. Take a seat, please. What I'd like to do is stand up. Sit down. You stand up. That's the entire test. Now, here's the deal. Patients that have tight hamstrings will usually feel better sitting. Patients that have disc lesions will really not feel good sitting. They'll feel better standing. Or déjà vu. There were three main tests that I said to you going in increasing order, from least provocative to more provocative regarding the disc. The least provocative one I said was Valsalva. The next one up from that is called Desjardins. It's either known as Desjardins side, or some people remember it as Desjardins triad. Now, that means three things: coughing, sneezing, and straining. When I lift both legs together, I got both hamstrings forward. Now the innominate as a whole is going to want to do what? Go back. So as it goes back as a whole, the legs up at less of a level, what's going to happen? Symptoms are going to come on earlier. Eli's heel to buttock. The way people remember it is they call it Eli's heel to contralateral buttock. Makes it easy for them to remember which side it goes to by saying that. When we then go and lift the leg up like this, it's putting some torquing and twisting into the pelvis and will also aggravate the iliopsoas. What's happening to the innominate when we do this? Wants to go anterior. So can that stretch the psoas? Eli's side. I'm bringing the heel to the ipsilateral buttock. That's Eli's side. What's preventing that hip from going anterior right now? The table. So instinctively, what will the patient do to allow that innominate to rotate? She'll take her hip, she'll rotate up like this, and frees the innominate to rotate. That would be a classically significant Eli's sign, indicative of rectus femoris contraction. Knock-lift, when I bring the heel to the ipsilateral buttock, the innominate already wants to go this way, and I now press down on the PSIS. I'm trying to facilitate its motion. This will aggravate an iliopsoas as well. This is called a knock-lift. This is called angles. Folks, angles is the third test of the three tests for a disc that go in that increasing order of severity. The first one, Valsalva maneuver. The second one being Desjardins. This one, angle, is the most provocative. So therefore, don't start with doing an angle. Always start with the least provocative, the one that you may get the information about hurting the patient. So in this one here, your patient is seated. That would affect a patient with a disc lesion. We've already agreed on that, correct? Now ask the patient to drop their chin to their chest. So now the patient is seated. They got their head dropped. Ask them to bring both legs out in front of them. Now, is she utilizing intra-abdominal pressure and stuff like that to maintain that straight out? You bet. And now the third part of this test is have them take a deep breath, bear down, and try to, like a bowel movement type of motion. Can you see where all three positions here, plus the patient's seated posture, is provocative for a disc lesion? Now, What you're going to do is you're going to have the lower leg bent a little bit to give them a little bit of stability on the table. Bend your knee. There you go. Now, on the top leg, take your superior hand, place it on the PSIS. Take your inferior hand and grab the ankle. What we're going to do is I want you to try to keep this leg straight first. And you're going to bring the leg back like this. When you've gone as far as you can, now bend the knee. It's a heck of a stretch, isn't it? Okay? Now, we're stretching the quads, but we're also stretching the femoral nerve. The femoral nerve is your motor power nerve to the quads. What will they feel? Anybody ever stick their finger in a socket? That's what they're going to feel running down the front of the leg. Not a pleasant experience. So we're going to have digit number 2. On L5, we're going to have digit number, the middle digit, on the sacral base. Now, I'm going to take her leg and I'm going to raise it on up. Pain is going to be happening either before, during, or after my fingers spreading. I'm at the lumbosacral junction, right? So, pain comes on before my fingers move. It has to be lower down than the lumbosacral junction. Would that be right? So that would be what? SI. If the pain comes on as my fingers are starting to move, I know it's lumbosacral. And if it comes on after my fingers have moved and are no longer moving, we're talking about lumbar. And the hyperextension test, flip over. Now, I'm going to ask you to put her arms out in front of her. Now, what I'd like you to do is, I'm holding onto her ankle, I'd like you to lift your torso up without using your hands. And after you clap for me, go. Okay. Now, she lifted her back up off the table on her own power. And that's why the hands are in front. So she's not lifting herself off, pushing with her hands. Is she using her paraspinal muscles here to do that lift? So if she had erector spinae spasming, would that be painful? If she had facet irritation, would that be painful? How would we distinguish between the two? Now, I'm like this, and now I lift up. What am I doing that she didn't do? Well, I'm right. She didn't use her muscles there at all, did she? What did I do? I lifted her up. If she still had the pain, where would it be coming from? And if the pain went away, erector spinae. What we're going to do is we're going to go up on our toes, and when I say drop, what are we doing to our internal viscera? Aren't we shaking it? So if you had a kidney stone, would that be painful? Where does the patient feel their kidney when it becomes a stone and it becomes aggravated? Around the flank, going into the groin. So it's going to be like this. Then take the ulnar side of your fist and you're going to strike. Your hand absorbs a lot of the shock, but it still aggravates the piriformis. Now, if the piriformis is irritated and it's entrapping and aggravating the sciatic nerve, this patient will feel shooting pain going down the leg. What happens if you hit here, but instead of the pain starting here, it started up here and worked its way down? Because this has been disco in nature, because it's part of the body. That's a different type of discomfort. Got it? So it's where we're hitting, down or above and down. Lewin standing. What you're going to do is ask the patient to stand. And you're going to look at the patient and see, do they stand with their knees bent or locked? If the knee is bent, what you want to do is you want to try and challenge it a little bit. So if she's standing with her knee bent, place your hand here, bring the knee in, force the knee back into extension. Now if it's an extension, let go. If the knee pops out like this again, what's it telling us?
Tight hamstring.
And you got tight hamstrings. Ask your patient to stand and ask them to grab their knee like this and stand. Okay, what are we doing here? What am I doing to the hamstring? Stretching it. What am I doing to the innominate on this side? Posterior. What am I doing to the lordosis? If the patient had a disc lesion, what would they feel? Increasing discomfort. If the patient had a facet problem, what would they feel? Decrease in discomfort. If the person was a malingerer, they would look at this and go, oh, I just can't do it. It's too complicated. Middle group, easy test. Technically, folks, what you're going to do is with the patient supine, you're going to ask the patient to raise their feet together off the table about 3 to 4 inches, and you're going to ask them to maintain that posture for about 30 seconds. All you have to do is ask your patient that has true low back pain to get up from the seated posture, and they're going to need help. You get the help by doing this, you get the help by doing this, they may even get the help from somebody helping them out of position. Either way, it's their body's way of trying to adapt to a bad situation. In the neck, we called it a rust sign. Remember that? In the lumbar, we're going to call it a miner's sign. So if you grab the area of the kidney, and now do this. What am I doing to the kidney? Am I jarring it? Okay. Where is the patient going to feel it if they have a kidney problem? Here, around the flank, into the groin. So give me a good follow-up test for a Murphy's punch test. Jar drop test. In the area of the PSISs, and somebody that's wearing their underwear, or can be bathing suits or something, sometimes you see these little silver dollar impressions. You know what I'm talking about? Yeah. Those are called your dimples of Venus. So, if you palpate the PSIS, or you see those dimples of Venus, and you bisect it, take your skin marking pencil, make a dot. Now take your tape measure, and you're going to measure 4 inches up from that dot. Now, what are you going to do? You're going to place another dot, make another dot here. Now, from that original dot, go 2 inches down. Now, folks, you're getting very close to butt crack here. So you really need to let the patient know that this is truly a legitimate test, which it is, and let them know what you're going to do before you do it. So now, from here to here, this was the dimples of Venus. This is down. From here to here, how many inches do we have? 6 inches. So, in that position, if you now ask the patient to bend forward, bend all the way forward, look at what happens to the distance. Does it get bigger? If it gets bigger by at least 2 inches, we're good to go. If we don't get that increase, we've got something that's preventing those areas from segmenting or separating. What could be causing that? That would be ankylosing spondylitis. I'd like you to grab your knee, bring it to your chest and leg. Stay, don't move. What's happening over here, folks? I can get my hand over here, can't I? Part of this is because she's wearing pants that are tight. But if she was properly down in the artifact, if I saw the knee coming up like it is, this is hip flexor contraction. Think about what's going on. She's got her hamstrings pulling, so now I'm going to go which way? Posterior. This leg is out this way. Which way does this innominate stay? Well, this way. This innominate will feel much more better going which direction? Posterior. In order to do that, what does it have to do? Bend the knee. This test here is going to decide for you whether or not you have a patient that has a medial disc or a lateral disc. It's called chemist. Antalgia means it's your body's position that it's going to adapt to make you feel better. So, this test, Kemp's test, is designed to do one thing: to pull the patient out of their antalgic position in order to exacerbate their complaint. If she's got pain down the left leg and she's leaning to the right, I am thinking that she has a lateral disc. Now, when I decide to test this, I'm going to pull her out of her antalgic position and bring it towards the side she doesn't want to go. Okay? Now, let's say Dr. Becky has pain on the left leg, but she's leaning to the left. Again, I am observing this. She's leaning to the left. I'm thinking medial disc protrusion. You would ask about a disc disease, a medial disc protrusion. Now, in this, if I take her and she's leaning to the left, and I ultimately want to pull her to the right, that would be pulling her out of her antalgic position, wouldn't it? In this case here, she's got pain here and she's leaning to the right. If I pull her now, which way? To the left, I'll be pulling her out of her antalgic position. So this is how the test is going to be done. First, observe your patient. Give a note on the side of discomfort. Patient is antalgic. Now, the first thing you're going to do is ask the patient to cross their arms. So cross their arms. On the side that they are antalgic to, and in this case she's leaning which way? To the right. That shoulder is going to be rotated back. Now, which way do I want to take the shoulder and pull it? Towards which way? So I'm going to place my hand here and I'm going to do this. Got it? So I just pulled her out of her antalgic position, didn't I? Did you see that? Now, she's leaning to the left. Hand is down the left. Which shoulder am I going to rotate first posterior? The left one. Now she's still leaning to the left, isn't she? Which way do I want to pull her? Take this hand, and here I'm going to do this. Got it?